Welcome to our CME and SDMS CME accredited ultrasound webinar, Inclusion of Body CEUS in Current Practice Guidelines. My name is Matt Wilson, representing the International Contrast Ultrasound Society, ICUS, in collaboration with Northwest Imaging Forums, the CME provider for this program. Northwest Imaging Forums is accredited as a CME provider by the ACCME. Northwest Imaging Forums designates this CME activity for 1.5 Category 1 credits towards the Physician's Recognition Award of the American Medical Association. Sonographer SDMS CME is also provided for those wishing to receive up to 1.5 hours of credit. The planner of this CME activity has nothing to disclose. Please find the Q&A button on your screen's lower menu bar to readily ask questions of the faculty as you are listening to their respective presentations. They will respond to questions in the discussion period towards the end of our time allotted. It is now my privilege to introduce our faculty: Richard G. Barr, MD, PhD, FACR, FSRU, FAIUM, Professor of Radiology, Northeast Ohio Medical University, Rootstown, Ohio, and Stephanie Wilson, MD, FRC PC, Co-President of ICUS, Clinical Professor of Radiology and Gastroenterology, University of Calgary, Calgary, Canada. Dr. Wilson.
Thank you very much for that nice introduction. And I will now like to make some welcome remarks from ICUS. Except that now I don't have that presentation showing anymore. Hello, I'm Dr. Stephanie Wilson from the University of Calgary in Canada. With Steve Feinstein, we are the co-presidents of ICUS, the International Contrast Ultrasound Society. And so I'd like to welcome all of you to our webinar today. First of all, what is ICUS? So ICUS is the only global professional medical society solely dedicated to promoting the safe and medically appropriate use of CEUS to improve patient care and save lives. Everything we do focuses on CEUS. So ICUS offers free CEUS webinars and live programs. It also offers free ICUS weekly news monitors with Mandarin translations performed courtesy of Professor Pintong Wang. It allows free access to ICUS website with comprehensive CEUS resources, free virtual exhibits, and live exhibits for sponsors. As well, we are noted for our advocacy for appropriate CEUS labeling and payment, and really very, very much more. So ICUS members are now found in 60 countries of the world, and you can see these marked in green. So this gives us a tremendous amount of scope in terms of the membership and the people who are interested in what we do. So the ICUS board is comprised of renowned global CEUS experts, including, as marked by the red circle in the center, Dr. Pintong Huang, who represents Asia on our board. So ICUS gratefully acknowledges its sponsors. So we have sponsors at the platinum, gold, silver, and bronze level. And you can see our sponsors listed here, and these are very valuable to us, and we do gratefully acknowledge their support that allows us to function. So the ICUS website is a dynamic one-stop shop for the global CEUS community. It provides comprehensive resources for CEUS around the body and around the world. It bridges medical subspecialties, including cardiology, radiology, hepatology, gastroenterology, vascular, and really many more. So we have a webinar portal which offers case of the day, product information, protocols and guidance documents, and Bubble TV and Bubble blogs. For physicians, sonographers, nurses, patients, industry, and the public, This is indeed a great resource. So I'd like to point out some highlights that we have new this year. The first is a new mobile app, which is available 24/7 for CEUS. And so here you can earn free CME credits. You can find protocols, check out Case of the Day, the Bubble TV and Bubble blogs, and perhaps most important, you can connect with industry for personalized product questions and answers. And this is all from the convenience of your smartphone or your iPad. And this is, of course, available for Apple devices or Android devices. So what does ICUS do? Well, we have three major pillars of initiatives. First, contrast enhanced ultrasound education. Secondly, global CEUS communication. And lastly, but not least important, is our advocacy, all in the interests of great CEUS. So first of all, let's look at or speak about our joint webinars. So these are offered in English and are translated to Mandarin. And so this is just an example. I don't expect you to read this tiny print, but every year we have 12 topics that we present in addition to 4 suggested by CUDA. And so these webinars are all jointly sponsored. And the webinar today, of course, is a CUDA webinar with some North American participation. So we also have our weekly news monitor. And as I mentioned, compliments of Pintong Huang. This is translated to Mandarin each week. We also have exam protocols, which are recently recommended. And CUDA and ICUS, I hope, have a great future together. We offer close collaboration on CEUS education and innovation. We have joint CEUS webinars for Chinese ultrasound doctors featuring CEUS experts from both organizations. ICUS membership is free. The ICUS website and CEUS resources are available to all members. And we have expanded Chinese contributions to our Bubble blogs and case challenges. So we hope that you'll follow us and our friends on Twitter and on Facebook. And also I would like to point out that in September of next year, we will have our next International Bubble Conference. These are held always in Chicago, and these are offered free web access on live media. So thank you for your interest, and to join ICUS free of charge and sign up for ICUS educational programs, please visit our website at www.icus/society.org. Thank you.
Welcome, everyone. I'm Richard Barr, and Dr. Wilson and I will be doing this webinar today. We're really going to talk about inclusion of body CUS in current practice guidelines. I just want to give a brief introduction. I do have many conflicts of interest, and I am the treasurer of ICUS. So just as an overview, there are imaging guidelines that have been published by several organizations. The most important are the World Federation of Ultrasound and Medicine and Biology, WFUM, the European Federated Societies of Ultrasound and Medicine in Biology, EFSM, as well as the Society of Radiologists in Ultrasound, the SRU. And these guidelines are all developed based on the literature, and they provide instructions on not only how to perform the examination in many, many different organs, as well as how to interpret the examinations. Again, just to go briefly over, we have many, many advantages of CUS over other imaging modalities. It's a real-time assessment of vascularity versus the snapshot that we see with CT and MR. And this is very critical, particularly if we want to do quantitative ultrasound, or as I will show you in my talk on kidneys, on lesions like papillary renal cell carcinomas, where the enhancement only lasts for a few seconds and is easily missed on CT and MR. The ability just to subtract out background soft tissue, so we have a contrast only image, allows us to see very small. We can actually see individual bubbles, so a very high resolution of the enhancement patterns. We have a narrow ultrasound beam, which is sub-millimeter, allowing for improved visualization of vascularity in small structures, as well as septations or small mural nodules. Obviously, we have no ionizing radiation. These are true intravascular agents, so they remain within the bloodstream. And I don't know if Dr. Wilson is going to mention this, but again, they do not cross the placenta, so we can use these in pregnant patients, and this is really the imaging modality of choice for those patients that are pregnant and have an abdominal pathology that needs to have a contrast study. They have a relatively short half-life, although that continues to increase as the machines have gotten better and better, but it's approximately 5 minutes, and we can do multiple injections if we need to, and there's no renal or hepatic toxicity. Who are the prime candidates for ultrasound contrast? Obviously, those with renal insufficiency are primary candidates. Every patient with cancer deserves to have a contrast study to evaluate for metastases. And these patients cannot receive CT or MR contrast, which really limits our ability to treat these patients properly. Allergies to iodinated or gadolinium contrast, immobile, ER, or unit patients, since we can bring the machine to them. Claustrophobic patients, pacemakers and metal artifacts that may limit the ability for a patient to get MR. Patients that can't hold still. We have extremely high frame rates, so even if we're doing a child that's moving around, we usually are able to get enough frames of good information to come up with a diagnosis. We don't have to sedate these patients to get an MR or a CT. Patients with lesions that need need thin slices, such as septated lesions. Patients that have lesions where contrast timing is critical, as in focal nodular hyperplasia. Lesions where visualization of small amounts of blood flow are important, like post-RFA or post-cryoablation. And again, pediatric patients to limit the amount of radiation they receive, as well as the amount of sedation. I do want to point out, this is in the SRU guidelines. We went through many of the organs in the abdomen, and we gave a level of evidence. What is the level of evidence for CEUS? So a 1 is the highest level, 4 is the lowest level, and A is higher than B. So we give 1A, meaning the highest level of evidence, for characterization of focal liver lesions, for guidance of procedures in the liver, for characterization of renal masses, and the guidance for procedures in renal procedures. We gave a 2 for the detection of focal liver lesions, as there just is not enough studies yet to do this, although we will be publishing a paper on renal masses showing that the CEUS is equivalent to CT and MR in detection of renal masses. For pancreas and spleen, we gave a 3. There is some literature that it's helpful, but not enough at this point in time that we feel we can really comment. Small bowel, which Dr. Wilson has really led this going forward, we gave it a 1B, very useful for the assessment of fibrosis versus inflammation in small bowel. Scrotum, a 3. If we look at, again, ovaries and breasts being used with some positive information, but not enough for us to really say that it's a method of choice now. Thyroid and parathyroid, we gave a 4. Actually, I find this extremely helpful in guiding biopsies because we've had several lesions where we did an FNA and got insufficient sample, but when we did a CEUS and can see where the vascularity is in a lesion and targeted that, we've been able to find that these were cancers that we've missed in the past. For endoleaks, extremely good. We gave that a 1B. Prostate, we do reasonably well, but the problem is BPH is very vascular and is very difficult for us to evaluate in the peripherals, in this central gland. For quantification and drug delivery, these are moving forward relatively rapidly and may be really important for treatment of patients in the future, but not ready for prime time yet. And vascular for transplant evaluation, extremely good. Again, these are the published guidelines. They're all available free online, and most of them also give you detailed instructions on how to perform the exam, as well as how to interpret the examination. So with that, I'm going to turn this back over to Stephanie, and she is going to go over the liver portion of this talk. So Stephanie, you're on.
Thank you very much. And I'd like to start off by apologizing for us having a recorded introduction for our presentation today, which was from months ago when we combined with CUDA in China. But on behalf of ICUS, I would like to welcome everyone to this presentation. So in my talk, I'm going to talk about liver contrast enhanced ultrasound, looking at North American guidelines that help our clinicians decide which tests we should use. I'd like to acknowledge Christine Merrill, who is my lead sonographer and of great assistance to me, not only running a wonderful department, but in doing these educational pursuits. And so my disclosures are minimal and Christine has no disclosures. So the story begins with an investigation of the status of North American guidelines for imaging liver nodules with CEUS. And to our dismay, when we looked outside of the organizations such as SRU and AIUM, we really found minimal written documentation in support of CEUS within the guidelines. Therefore, today what we will do is share our knowledge regarding these guidelines and hopefully provide insights for the future. So our objectives are to show the historic misconceptions of the role of CEUS in the liver, and to highlight the role of CEUS today within AASLD guidelines, NCCN guidelines, ACR appropriateness criteria, and CEUS LIRADs. And so we'll identify the current issues and recommend optimal resolution where possible. So let's start off with AASLD, the American Association for the Study of Liver Disease. So this is an evidence-based practice guideline to recommend diagnostic, therapeutic, and preventative aspects of care. And here we're focusing on hepatocellular carcinoma. And so what about their guidelines? Well, in 2005, the liver imaging guidelines did include contrast-enhanced CEUS along with CT and MR scan in keeping with the fact that microbubbles were approved in Europe and in Asia and in Canada around 2002. However, in 2011, CEUS was removed from the guidelines and never seemingly to be seen again. So in 2018, CEUS was still missing, and we know that there's a new version pending release in 2023, and we know ahead of time that this does again not include contrast-enhanced ultrasound. So we believe it's very important to be aware of the misconceptions that occurred after 2005 when the microbubbles were approved for inclusion. So these are largely European publications, and they came to two conclusions, which I cite. First, that CEUS is not accurate enough to differentiate HCC from cholangiocarcinoma, which we abbreviate ICC. And secondly, that CEUS cannot see the progressive enhancement of cholangiocarcinoma, which is the hallmark diagnostic feature on MRI. Therefore, it cannot detect ICC. So people felt it was reasonable to remove CEUS from the guidelines. Now at the bottom in gold, you can see I've said that both of these conceptions have been proven to be wrong today. And we know that CEUS can accurately and very easily diagnose both HCC and ICC. And furthermore, we know that CEUS shows rapid washout in cholangiocarcinoma, which is appropriate. This is a malignant tumor, and washout is the key feature for malignancy. And the enhancement which MRI has described in the past actually represents pseudo-enhancement related to the MR and CT contrast agents which pass into the interstitium. And of course, as Richard mentioned, the microbubble contrast agents remain purely intravascular. And so these misconceptions led to the removal of CEUS from the guidelines in 2011. And I cite here the publication from the authors of the guidelines. Now, ultimately, the removal of CEUS was disputed by other authors. And again, I cite only two examples, both published in Hepatology. But still, in spite of the dispute regarding this and people refuting what AASLD had claimed, CEUS remains absent from the liver guidelines as of today. So let's look at what they suggested. So they said that CEUS cannot differentiate ICC and HCC. So I'd like to show you very classic examples. So we see two nodules in two different patients on the baseline grayscale scan. In the arterial phase, you can see that both of them show arterial phase hyperenhancement. And then by 1 minute is a pivotal time on an ultrasound scan of the liver. You can see that on the top line in patient 1, the nodule is invisible because it's iso-enhanced with the liver parenchyma, whereas on the bottom line in the classic cholangiocarcinoma patient 2, you can see that there's big washout of this nodule by 1 minute. And when we look further, we can see that eventually at 5 minutes on the top line, we do get late week washout in the hepatocellular carcinoma, whereas on the bottom line, we can see progressive washout so that it's marked by 2 minutes. So late and weak washout is characteristic requirement for HCC, whereas rapid marked washout is classic for all non-hepatocellular carcinomas, including cholangiocarcinoma. And so what's the pivotal point that we record on all patients is that 1 minute timing. And of course, if we see rapid washout, it's washed out by 1 minute. If we don't, a late washout, it will still be iso or hyper enhanced. The second claim that they made was that there was inability for ultrasound to show the enhancement, the delayed enhancement shown on MR. So let's look at this patient with cholangiocarcinoma. So you can see on the top line, the MR shows the tumor. On the image on the left, shows arterial phase hyperenhancement on the image in the middle. And then on the image on the right, we can see that there's no washout. The contrast is maintained. So they claimed that this represented delayed enhancement, whereas it didn't. It represented pseudo-enhancement from contrast in the interstitium. If we look at the beautiful case on the bottom, we see the nodule on ultrasound. We show the APHE, and then we show at 1 minute that it's starting to fade less than the enhancement of the parenchyma. So that represents rapid washout, which becomes marked by 2 minutes. These are very easy to follow observations on CEUS and shows that the discordance from interstitial contrast is in ultrasound's favor, truly showing the vascular changes. Now, let's look at these AASLD guidelines. So the first thing that they address is liver surveillance. So the motive of the AASLD guideline is that we want to detect hepatocellular carcinoma while still small and treatable. So grayscale ultrasound is recommended worldwide for liver surveillance in high-risk patients at 6-month intervals. And a positive scan shows a new nodule or a change in an existing nodule. So on nodule detection, a contrast imaging modality is recommended by AASLD to characterize the masses. So the current guidelines recommend contrast-enhanced MRI and CT scan, and they do not include CEUS. Nonetheless, we have extensive experience in characterization of these nodules. So let's look at a case. So here we have a 66-year-old male with NASH cirrhosis, and he has a positive surveillance ultrasound. So he's referred, according to the guidelines, appropriately for MR scan. But the MR scan dictates a report and observations show no correlate. They don't see the nodule from the surveillance ultrasound. So then the patient in my center is sent for ultrasound exam. So you can see that we do in fact show the correlate for the surveillance ultrasound. And when we do the wash-in for our CEUS exam, you can see there's the nodule and there's a black area, but a hyperenhancing nodule is present within and shown on the still image to the right. and there's no washout. This is therefore a LIRADS 4. So this lesion was presented to multidisciplinary rounds. It was decided to perform ablation with a biopsy, and this shows a moderately differentiated hepatocellular carcinoma. And so, of course, what do we conclude from this? Well, the contrast-enhanced ultrasound, as the same modality as the surveillance scan, will consistently show better correlation with surveillance ultrasound than MRI. So in our own published study shown at the bottom, you can see that we did 195 consecutive positive surveillance scans with ultrasound and MRI performed in a timely manner. And ultrasound CEUS showed 97% correlation, whereas MRI showed only 78% correlation. So 42 nodules were not detected on MRI. And of those, we proved on CEUS and biopsy that one was a cholangiocarcinoma and that two were hepatocellular carcinomas. And so we conclude from this that the guidelines should change, that CEUS should be recommended as the first test following nodule detection on surveillance. We are not suggesting to get rid of MR, but ultrasound with CEUS is the best first test to confirm the validity of the observation. So let's go on to another AASLD guidelines, which deals with indeterminate nodules on MR. So the motive here is to resolve the nature of an indeterminate MR scan. And they recommend follow-up imaging or an alternate modality or contrast agent. And so this includes CT or MR scan. And we're very familiar that an inconclusive MR very often includes a report that suggests to repeat the MR in 3 months. They additionally do make a very good recommendation against routine biopsy of every indeterminate nodule, in that it's been proven that many indeterminate nodules are benign. And of course, CEUS is still not recommended. Nonetheless, we in Calgary have extensive experience in resolving indeterminate nodules from MR. And in fact, resolution of these indeterminate MR and CT results comprises the biggest single indication for liver CEUS at our institution. So let's look at another example. This is a 69-year-old male with hemochromatosis, and his MR scan shows a T2 image on the left, and it's got a bright nodule. And so the liver is unusually dark, but the interpreter just commented on the T2 bright nodule. And then you can see the progressive rim kind of looking enhancement that they see in the arterial phase, early, mid, and late phase. And they made an erroneous interpretation of a hemangioma in an at-risk liver. So this patient was also sent for contrast ultrasound, and we're not showing the grayscale picture, but you can see on the wash-in that we have a rim hyper-enhancing nodule. By 30 seconds, we see the picture with the rim hyper-enhancement. And at 1 minute, you can see the parenchyma is more enhanced than that rim. So we have early washout. And 2 minutes, it's become much more marked. So this falls into the non-hepatocellular malignancy requirements. And so this requires biopsy, and this shows that this is a cholangiocarcinoma. And so this provides a very, very good value on CEUS. So hemochromatosis is known to create a challenge for MRI, and it makes the liver dark on T2 imaging. So therefore, the T2 bright nodule is uncertain because the background liver has changed. So they made an erroneous interpretation of a T2 bright nodule, and then an erroneous interpretation of a benign lesion hemangioma, when in fact, CEUS shows the rim AFI with clear rapid washout, suggesting a malignant non-hepatocellular malignancy requiring biopsy. And so here, what's our suggestion? Well, certainly CEUS should be included in the current guidelines, and CEUS helps to overcome many of the MR limitations that come from excess fat and iron in the liver parenchyma. So from AASLD perspective, we have shown two of countless examples that we have showing the incredible contribution of CEUS in liver imaging in those at risk for HCC. Now, I'm just going to mention OPTN and UNOS, and so this, of course, relates to organ transplantation, and currently CEUS is not included for these situations, and so I've left it out of this presentation. So now I'd like to change gears and go to the NCCN guidelines. So this is the National Comprehensive Cancer Network. So it's cancer-focused, guiding management decisions and interventions in most cancers in the US. And the thing that was difficult for us in looking at this is that every single cancer has its own independent section of the NCCN. So we looked at ones that are relevant to us. And so we looked, for example, at patients with colon cancer. So the recommendation from NCCN guidelines is that to detect small metastatic lesions in the liver, they recommend the patient have a chest, abdomen, pelvic CT scan every 3 to 6 months from surgery date to 5 years. And again, there's no mention of performance of CEUS. Nonetheless, we also have considerable experience with metastases. And so we found that CEUS techniques for identification and characterization of metastases with CEUS are really very valuable. And so they include, first of all, always sweeping the liver in the portal venous phase. And so the liver parenchyma will be enhanced and stay nicely enhanced for somewhere between 30 seconds and about 4 minutes, in some people longer. And so when the liver is enhanced, metastases, which are characterized by rapid washout, will appear as a black hole in the liver. And so they have increased conspicuity over baseline. Therefore, we can see more and smaller metastases with the portal venous phase sweep than we can see on baseline. And we can see metastases that are occult on baseline. So once we have these small black holes that we can see in the liver, we inject on top of the washout zone, and this shows us the arterial phase characteristics and washout timing of the identified nodule. And we know that metastasis on CEUS may show some variability of the arterial phase features, ranging from hyper-enhanced globular to hyper-enhanced rim, but generally we show at least transient arterial phase hyper-enhancement. And although that's variable, what is constant is that they are characterized always by rapid and marked washout, giving us the value on the sweeps. So let's look at an example. A 50-year-old male with colon cancer. So first of all, you see the top picture on the left, CT scan, the arrow pointing at a very small, low attenuation lesion. And so we see countless patients every year coming with a CT scan that shows these low attenuation lesions, and they're indeterminate. So here they follow the guidelines from the AASLD. They recommend doing MR. So the MR shows the same tiny lesion with no enhancement. So both the MR and the CT scan are indeterminate. So if we look at the bottom line, we can see that this is an image on the left taken from the portal venous phase sweep. So you can see that black hole that it shows. And so when we look on the center, the moving screen right now, there's the black hole, the bubbles are coming in, the kidney enhances avidly first, and then you can see that the black hole has rim APHE. So rim APHE, and then when we look on 20 seconds on the right-hand image, we can see the rim has disappeared. So what do we know? We know that there's APHE rim hyperenhancement with rapid washout, creating that washout zone from the portal venous phase sweep and confirming a metastasis in the liver. So what do we think? So CEUS has a purely intravascular contrast agent, and it is better at washout detection. And this, of course, is the biggest indicator of malignancy. And so resolution of indeterminate CT and MR in patients with early small metastases is an unbelievable strength of CEUS. And so oncology patients would benefit from the inclusion of CEUS to NCCN guidelines. And so certainly in our own center, we're recognized as not the test to detect all metastases, but we are the problem solver in our cancer center. And there are countless indeterminate CT and MR scans which arise in this patient population. So what about LIRADS? So LIRADS is a bit different. So the liver imaging reporting and data system is a total focus is on the at-risk patient for HCC for the characterization of liver nodules. And so the great news, and as compared to AASLD and NCCN, is that CEUS LIRADS is already incorporated into LIRADS for CT and MR scan. And so LIRADS and the other guidelines have differences. So from our perspective, we feel that the guidelines are directed oftentimes at the referring clinicians, in that it helps them to decide on appropriate imaging for a situation. And LIRADS, by comparison, is directed at the person performing the scan and assists them with consistent reporting and interpretation of images, consistent communication with colleagues and clinicians, and consistent management of patients. And so both of these limbs are essential, and both require knowledge of the beneficial aspects of CEUS. So the CEUS LIRADS categorization for liver nodules, their motive is to make a category which is called LR5. And it is to have close to 100% specificity for HCC. And what this does is it allows for treatment without the requirement for biopsy. And this was an essential issue for the many patients at risk for HCC all over the world, including North America. So the criteria for LR5, we looked at this briefly already. For HCC, they're very similar between CEUS and MRI, and therefore we expect frequent concordance. And so these criteria are a nodule over 1 centimeter, arterial phase hyperenhancement or AFI, and late week washout. And so because they are similar criteria for CEUS and CT and MR, they're often concordant studies. So here we see such an example, a 75-year-old male, HBV cirrhosis. You can see on the left-hand panel a nodule on both studies, MR on the top, CEUS on the bottom. In the arterial phase, the nodules are hyperenhancing, and in the later phase, we can see that they both show washout, and the MR shows the pseudocapsule. So both of these are LR5, and the result would be the same. Now let's look further. So another motive for LIRADS is to accurately evaluate precursor nodules for HCC. So LR4 is such a category, and it is highly suspicious for HCC, but it requires biopsy for confirmation before treatment. So what we know is that CEUS will show more LR5 than MRI. And one of the benefits of interpretation of these exams together, and the advantage, of course, is that whenever we have LR5, we reduce biopsy, which is better for the patient and also saves money. So let's look at such an example. So here's a patient with cirrhosis. A surveillance scan shows a nodule. So when we look on the left-hand pictures, we can see the nodule on the MR at the top, and the arrow pointing to the echogenic nodule on the ultrasound at the bottom. When we go to the arterial phase, we see the APHE on both exams. However, on the MR scan, there's no washout, whereas we can see the arrow pointing to the washout zone on the CEUS exam. So one is LR4, requiring biopsy. The CEUS is LR5, not requiring biopsy. So this discordant result shows washout on CEUS only, and therefore it's an upgrade from LR4 on MR to LR5 on CEUS. And this is a frequent occurrence. And the LR5 diagnosis negates the need for biopsy. So CEUS LIRADS guidelines for characterization are critical, and we acknowledge that CEUS is better at washout detection, and interpreting CEUS and MRI has great benefits when they're interpreted together. So we'll finish with the ACR. So the American College of Radiology makes appropriateness criteria. And so these criteria are classified as looking at the imaging test and the indication. The imaging test may be usually appropriate, it may be appropriate, or usually not appropriate. So let's look at two scenarios. So if we look at liver lesions less than 1 centimeter, we can have those in an incidental finding in a chronic liver, and they can come from non-contrast CT or MR or from ultrasound. So we're obviously looking there in the chronic liver for HCC, or we could have an indeterminate nodule with extrahepatic malignancy from CT or MR or ultrasound. So here we're looking for HCC, here we're looking for METs. So the ACR recommends initial characterization with contrast in all scenarios. And so MR imaging is always listed as usually appropriate, and CEUS is listed as may be appropriate. And so although this causes me some dismay, we have to remember that CEUS has only been added to these guidelines for the last 3 years. So having a mention at all is better than nothing. And so certainly we would like to change that, but not at this moment. Now, representative scenario 2 is looking at liver lesions bigger than 1 centimeter. And so these can be indeterminate with an extrahepatic malignancy on ultrasound, again, MR, or on CT. And the ACR recommends characterization with contrast, including usually appropriate for CT and MR, and only may be appropriate for CEUS. So this shows merely further work is required, but we've made great strides to be included in these recommendations. So noteworthy comments include that current appropriateness guidelines give no indication of what to do when contrast MR or CT is indeterminate, only non-contrast, another area we would like to address because we do so well there. And that CEUS inclusion in ACR appropriateness criteria has occurred only within the last 3 years. And so this major step hopefully precludes increasing rank for CEUS relative to other modalities in the future. So I'll end with one case, and that would just be to emphasize my own personal sentiment that CEUS is basically good for all liver imaging. So let's look at this patient, a female, no known risk factors. She had this ultrasound in 2019, and you can see they commented on a little cluster of cysts marked by the arrow, but they didn't comment on this little solid halo that surrounds these small cysts. And so the patient has a second MR scan in 2022 after having one in 2019 that was indeterminate. So at this time, we have a T1 bright nodule, and therefore we use subtraction technique. And when we look for the arterial phase enhancement, there's little bits of signal in there, but it's very uncertain as to whether there's enhancement or not. And on the delayed imaging, we see this again, what they call delayed enhancement, which suggests possibly interstitial contrast, but this is an indeterminate result. So the patient comes for ultrasound, and so here we can see when we inject the contrast, which I'll just wait for this clip to run. So there's the injection of the microbubbles we watch from the start, and you can see that this nodule is in fact not a cystic nodule, it's uniformly hyper-enhancing nodule. And when we look at 1 minute, we can see weak washout, and by 2 minutes, marked washout. So that is a malignant pattern on ultrasound, full stop. So it suggests to us a malignant non-hepatocellular malignancy, and this was actually surgically removed. We believed it would probably be cholangiocarcinoma, but it is a non-hepatocellular malignancy, but it turns out to be a metastatic ovarian cancer. And so what do we know from what I've shown you today? Well, we believe that CEUS is gaining momentum as a credible modality for the diagnosis of focal liver lesions. And current guidelines need to reflect the importance of CEUS and its contributions. Thank you very much for your attention. And I'd like to hand the microphone back now to Richard Barr, who will talk about guidelines and the kidney.
Thanks, Stephanie, for that wonderful talk. There really are not a lot of guidelines for the kidney, so I'm going to give you mostly what our experience is. We've done somewhere between 4,000 and 5,000 indeterminate renal masses over the last 15 years that we've been doing CUS of the kidney. Excluding inflammatory masses, vascular abnormalities, and pseudotumors, most solid unenhancing renal masses are malignant, and complicated cystic lesions with enhancing soft tissue components, excluding the actual cyst wall, are usually malignant. However, there is a wide range of complicated cystic lesions between the obviously benign and the obviously malignant lesion. So we used the Bosniak classification, which was developed in determining the probability of malignancy on these lesions, originally developed for CT and has been expanded to include MRI. And in the recent 2019 update was further developed to help decrease the need for interventional procedures for false positive cases. So CEUS has been successfully used in several institutions worldwide to accurately characterize renal masses and guide management. While papers have been published recommending how to interpret CEUS renal ultrasound, a Bosniak classification for CEUS has not been developed. Several publications have proposed a CEUS Bosniak classification system. However, the radiology community has not yet solidified around one set of definitions and criteria. The classification system is based on the probability of malignancy for the various enhancement patterns identified on CEUS. And again, the 2019 Bosniak for CT uses Hounsfield units to determine the probability of malignancy. Ideally, a dedicated CT protocol without contrast, contrast in the arterial phase, and a nephrogenic phase are needed to assign a Bosniak classification. However, many CTs are performed without only or with only, and the renal lesion cannot always be classified using the new Bosniak classification. The 2019 Bosniak classification protocol suggests that these patients should receive a dedicated renal protocol CT. However, this adds additional radiation, and the FDA has actually recommended that CT should not be used for this purpose. So we've been looking at our cases and trying to figure out what is the probability of malignancy for different enhancement patterns. So we recently published a study of 512 non-enhancing lesions of any complexity on B-mode imaging with up to 10-year follow-up with no change suggesting a malignancy was identified. Therefore, we can conclude that a simple cyst based on B-mode characteristics can be classified as having essentially a 0% chance of malignancy, and we call this classification 1. We can also conclude that any cystic renal mass with complexity, septations, calcifications, and wall thickening without enhancement has essentially a 0% chance of being or becoming malignant, and we therefore classify this as a classification 2. And again, we've had several hundred cases followed up to 10 years showing that we see no enhancement, that the lesion does not convert to being malignant. And here are just two examples. If you look at the B-mode image in these pairs, which is on the right, you'll notice that they appear identical on B-mode imaging, but when we do ultrasound with contrast, the one on the left shows not one bubble in the lesion and was a benign hemorrhagic cyst, versus the one on the right, which shows marked arterial enhancement and was a renal cell carcinoma. Sometimes we see individual bubbles traversing a septation or continuous single row of bubbles in a septation. And previous studies have suggested that the probability of malignancy is 0 for both of these patterns. However, we don't really have a publication confirming this, but we do classify this in our center as a category 2, essentially 0% chance of malignancy. And again, we have a small series of these with over 5 years follow-up, suggesting this is a benign finding. Uniform enhancement of a septation greater than 2 millimeters without enhancing nodularity. This pattern can be seen, and no long-term follow-up studies are available in the literature. We therefore really do not know the probability of malignancy in this enhancement pattern. In our institution, we request a 6-month follow-up study to confirm stability of this enhancement pattern. To date, the majority, if not all of these, have been benign on follow-up. We classify this as category 3, probably low malignant potential, but follow-up is required. Septation of any thickness with enhanced nodularity. In published studies with this pattern, this has a greater than 95% chance of malignancy, and the enhancing nodules can be as small as 1 to 2 millimeters and are often not identified on CT or MR due to volume averaging. We classify these as category 4, greater than 95% probability of malignancy. We do, in our series of about 1,000 lesions we published in 2014, that we had false positives that included infected cysts, 2 out of 500, and a couple oncocytomas, which obviously do show enhancement but are benign lesions. So here's an example comparing a CT without and with contrast on the 2 images on the left, and you can see we really do not see any septations on the without contrast, but we do see some septations in the nodule that's more anterior, but it looks pretty smooth. It's less than 2 millimeters, so this would be a Bosniak 2 based on the Bosniak classification. But when we do CEUS, we can see that there are a lot of nodules identified within this lesion. Here is the septation, but these nodularities suggest that this is malignancy, and this was a cystic renal cell carcinoma. In terms of enhancing nodules on the cyst wall, again, prior studies suggest that this pattern has a greater than 95% probability of malignancy, and rare cases of this pattern have been negative for malignancy, but again, represented an infected cyst. An example, CT scan with contrast in both the axial and coronal plane. This lesion looks pretty benign and has a Hounsfield reading suggesting that is probably benign. But again, when we do CEUS, we can see that there is an enhancing, relatively large nodule within this lesion that is really not identified at all on the CT scan with contrast. In terms of solid renal masses with enhancement less than normal renal cortex are seen. We can see enhancement pattern equal to or greater than renal cortex, and we also have echogenic renal masses. So how do we handle these? So although a formal study has not been published, it is pretty well recognized that papillary renal cell carcinomas often enhance less than the normal renal cortex, and although we don't know the sensitivity and specificity of this enhancement pattern, we hope that we will have some literature out that'll provide this information in the near future. For other types of renal cell carcinoma, the renal tumor enhances more usually than the renal cortex, and there may be areas of low or no enhancement representing necrosis. So here's an example of a CT scan without and with contrast. We go from average 11 Hounsfield units to 27, so less than 20 units, so this would be classified as a Bosniak 2 lesion. But on CEUS, you'll notice that there is significant enhancement throughout this lesion. So why the discrepancy? So what I've done here is pulled out frames from this case every 10 seconds. So you'll notice that at 10 seconds post-injection, we're starting to see some enhancement. We see maximum enhancement of this lesion at 20 seconds, and then at 30 seconds, we start to see less bubbles. And by the time we get to 60 seconds, there's hardly any bubbles left. So this is a classic pattern that we see with papillary renal cell carcinoma. And again, you'll notice the enhancement is never more than the renal cortex. So again, because we're doing snapshots on CT and MR, we're often catching them at this phase where we don't see the enhancement, and therefore they look like benign complicated cysts. Echogenic renal masses are somewhat of a problem, and again, we want to distinguish angiomyolipomas from echogenic renal cell carcinomas. So as a general rule, angiomyolipomas usually enhance less than the renal cortex and have a globular enhancement pattern with areas of fat showing little enhancement. So just like we would see on CT, we can distinguish the areas of fat within these lesions. An echogenic renal cell carcinoma usually enhance more than the renal cortex in the arterial phase and may show washout in the delayed phases. The sensitivity and specificity of this pattern is not truly known, but however, we have to recognize that fat-poor angiomyolipomas will have a similar enhancement pattern to that of echogenic renal cell carcinomas. And let's see if I could get both of these. I'm sorry. It's not going to let me play both at the same time. So let's play this one on the left. So here we have an echogenic renal mass. And as the contrast is coming in, you can see that there's a relatively significant enhancement. It's more than the renal cortex in this echogenic renal cell carcinoma with some areas of necrosis. If we look at the lesion on the right, again, an echogenic renal mass, and as we watch the bubbles come in here, you'll see that we see nice enhancement of the kidney, but the lesion itself shows very little enhancement, maybe a little bit of bubbles here and there. And again, the areas that are not enhancing are fat, and this is an angiomyolipoma. And we've had pretty good luck in using these rules in distinguishing an angiomyolipoma from a echogenic renal cell carcinoma. So to conclude the development of a Bosniak type classification for renal CUS, we need to know the probability of each enhancement pattern over a long period of time. And these long-term studies are needed really to determine how we can classify these lesions, and some results are coming in. And like I said, we've been doing these for actually almost 20 years, so we do have long-term follow-up, and we feel pretty comfortable in the rules that we're using in developing these based on our follow-up that we have published. Now, the other thing that I would like to go over, which Stephanie kind of touched on some of these in her talk, is common misconceptions about ultrasound contrast. So misconception number one, I don't get paid. So most radiologists are unaware that CEUS is in reimbursed for any radiology indication using any of the approved ultrasound contrast agents. So it's agnostic for organ, and it's also agnostic for the contrast agent as long as it's FDA approved. The new CPT code allows for billing not only the contrast study, but the non-contrast study as well, where these are bundled in CT and MR. There is a feeling that performing CEUS would decrease the usage of CT and MR and therefore decrease income. So we really need to educate people that there is actually good reimbursement for CEUS for any organ with any of the approved agents. And I've looked at a 6-month period of last year of what we got reimbursed. So we're looking at CPT codes for CT abdomen without and with contrast, as well as CT abdomen with contrast. And the MR data is somewhat similar, but a little bit more enhancement, more reimbursement. And if we look at, again, we're looking mostly at renal masses, 76770 echography, retroperitoneal complete, and 76978 ultrasound targeted dynamic microbubble first lesion. So our total professional reimbursement for doing a CEUS study, if there's only one lesion, we get $66 on CT and $97 on CEUS. So there's clearly more reimbursement. And if we have more than one lesion that we evaluate, we end up adding half of the 68, so another $34 for every other lesion that we evaluate. So it is truly a misconception, number one, that we don't get paid, and actually we get paid more for doing CEUS than CT or MR. Misconception number two, the doctor needs to be in the room for the examination. There's really no need for a physician to be in the room during the examination. I can be anywhere in the world, and these studies go on in our institution without a physician being in the room. The exam is saved as a cine clip, and we can select images that we send to the PACS, but we always have that cine clip to go back. If there's a question, we can always go back if your sonographer didn't pick out images that you like. And again, we've trained our sonographers that they select appropriate images for interpretation. So as Dr. Wilson has shown you for livers, you know, doing maybe a without a arterial phase hyperenhancement, a 1-minute washout, and a 2 or 5-minute washout gives you all the information you need to make a diagnosis. And again, don't forget that these bubbles wash out usually after 5 or 8 minutes. You can give a second injection, or you can inject over a previous injection, as Stephanie has showed you when we're evaluation for METs. And you can give as many as you want. When we did phase 2 clinical trials for DEFINITY, we gave 9 cc's of contrast and did not have significant reactions. We now use 1 cc. So we're giving 10 times less than we used to give. So there's no reason why you couldn't use multiple injections. And this is also true if you're doing interventional procedures. And it's really critical in RFAs because you can now do many contrast exams. So after you ablate a patient, you can rapidly do another contrast study while the patient's there to see if there's any residual tumor and reposition the needle and do another ablation. Misconception number 3, CT and MR are more accurate. So all studies reported for focal liver lesion characterization using CEUS have found it to be equivalent or better than CT and MR. Although we don't have a lot of studies on the detection of lesions, characterization of studies of focal liver lesions, there is actually a fair amount of literature. So if we look at cases that in the same time period, patient has received a contrast-enhanced CT and a contrast-enhanced ultrasound, 3 studies. Let's look first at the 2 on the right. You'll notice that the sensitivity of CEUS in both of these studies is significantly higher than it is for CT, as well as the specificity. So both of these studies show improved sensitivity and specificity of characterization of liver lesions with CEUS over CT. The study on the right by Quay, he only looked at indeterminate CT. And he's very consistent with Stephanie's results. He found that in those patients that had an indeterminate CT, in approximately 90% of the time, he was able to give an answer as to what the lesion was. So again, confirming Stephanie's results that CEUS is excellent in looking at indeterminate masses. There are 3 studies that directly compare within the same time period CEUS and enhanced MRI. And again, if we look at these 3 studies, 2 of them show superiority of sensitivity of CEUS over MR, and 1 probably equivalency. If we look at the specificity, 2 studies show significant improvement of specificity of CEUS over MR. The third shows equivalency. So every study that has directly compared CT and MR to CEUS has shown that CEUS was equivalent or better than CT and MR. Misconception number 4. There is not enough educational material to train sonographers and physicians. And ICUS is in the process, and it has developed a large set of educational courses on CEUS for ultrasound training programs. So these are now available to all ultrasound schools and can use this to train our upcoming sonographers how to do CEUS. ICUS again has made a big push, and IV training is now part of the ultrasound training program curriculum. So this should not be a problem as we go forward in the future. There are an enormous number of ICUS webinars, as this one will be, on various topics for both cardiology and radiology, focusing on both physician and sonographer training on the ICUS website. These are all free, and most have free CME. And again, when we poll radiologists, what are the problems? So they feel they do not know how to evaluate the quality of the exam. They don't feel they can trust their sonographer's assessment. So again, it's education, education, education. Another thing that comes up is they're not so sure about ultrasound anatomy. Obviously, on CT and MR, with the axial imaging or coronal imaging, it's fairly easy to determine where things are at. On ultrasound, it's somewhat difficult, and I think if you have a standardization of having your sonographers do a standard protocol where they do the different phases or positions of the liver, this does not become a problem. Again, not sure how to interpret the exam. There's an enormous amount of literature out there on how to do this. No reimbursement, as we talked about. You do get reimbursed, and actually you get paid more than CT and MR. Again, lack of awareness, knowledge, and attitudes, lack of stakeholder incentives, skill and training, lack of FDA approvals and indications. Well, this is really not a problem. We'll talk about that shortly. Lack of guidelines, and I've given you several guidelines that go over almost every organ in the body to tell you what you can do and when this is applicable, workflow issues, and the ability to add contrast at the time of a non-contrast exam if needed. So one of the things that we have done in our practice is we've educated referring physicians. So they can write an order, ultrasound abdomen without contrast, contrast if required. So in other words, if you're doing a screening exam and you find a nodule, and in there is that they add into the order contrast if recommended or needed, you can just go ahead and do it at the same time. This saves an enormous amount of time in diagnosing these patients and moves patients along in the system and eliminates the need for a lot of other tests. And again, most radiologists now have not been trained in their residency or fellowships, and we need to work a little bit more in getting this available. And unfortunately, we would like to see a lot more training programs and educational in RSNA, in other maybe SAR, so that physicians know this is available and how to use it appropriately. Although there's a large amount of material available online in webinars, they do not feel they have adequate training or experience. And again, the SRU, ICUS will be pairing with SAR again this year, and we will have a session on CEUS and how to do it. We are also paired with the World Federation of Ultrasound and Medicine Biology in November in Muscat, Oman. We have an all-day CEUS extravaganza on how to do CEUS and mostly almost every organ you can imagine. So there is educational material out there. And again, the ICUS website is filled with unbelievable amounts of information for you. And again, we hope that we have more continued publications on CEUS. Hands-on courses are somewhat difficult because of the need to give contrast. So it needs to almost be done in a hospital setting. We as suggested to the American Board of Radiology that CEUS questions are going to be added to the radiology boards, and hopefully working with the ACR and the American Board to include CEUS as part of routine resident training. Again, anatomy seems to keep coming up as well. I see this picture, but I have no idea where it's at. So again, it's educating the sonographer to provide that information. And most ultrasound machines have little cartoons of the organ, and the sonographer can actually mark exactly where that image was taken, and it'll be embedded in the image. So you shouldn't have that much of a problem in determining which segment of the liver it is. And again, maybe a little bit more training on ultrasound anatomy, and maybe developing of protocols that are standardized on how to do these imaging of showing vessels, so that we feel more comfortable in where these images are taken. Again, there's a lot of don't trust the sonographers. And again, there are educational courses. There are some hands-on courses that you can send your sonographer to that are all-day courses. I think it is very, very helpful for them to see some cases when they're there. We have a training program that occurs in our imaging center, which is an outpatient private practice center. And I think when everybody leaves, they feel very comfortable in doing these examinations. We're trying to figure out how we can get some kind of a certification for a lab or a sonographer. AIUM does offer a certification of a CEUS lab now. And again, we need to have some more ideas of how to recognize artifacts. And we recommend this to the Stephanie, that maybe this should be something that should be put on as an ICUS talk. Again, there's an enormous amount of literature and wonderful, wonderful images on how to interpret these examinations. So this really shouldn't be a problem. And most of these offer CME classes, so you should be able to do this. And again, I refer you to the ICUS website. It's free. You can see an enormous number of video clips, an enormous number of training by several experts in the field. And I think this would be very helpful. We do have Case of the Day, which shows significant cases, and there's a nice backlog or a collection of these cases now that you can go through and see how other people are finding this extremely helpful. One thing, again, that I mentioned early on that I thought Stephanie may mention but didn't mention, there are situations where you cannot give CT and MR contrast, such as in a pregnant patient. The only way we can really diagnose that patient is to do a CUS. And CUS is safe in pregnancy, it's safe in children, it's safe all the way around. The reaction rate is less than that of CT and MRI. Misconception 5, I can only do on-label adult and pediatric liver exams. Wrong. You don't have a problem in doing off-label CT and MR. That's never been a problem. And I think people are unaware of the vast indications for CUS. And my mantra for the last 15 years has been off-label is not off-limits. And we do off-label imaging every day in CT, MR, as well as in ultrasound. And again, to be able to do off-label, you need to be educated to do things that are appropriate. And again, I give you these 3 sets of guidelines that are available online free, which will tell you what is appropriate to do and what is not appropriate to do. ICUS continues to work with the FDA to get a whole body approval. Misconception 6, lack of guidelines. And again, I told you we have these 3 guidelines that are available free, and I'm not going to continue on that. Workflow issues. So we get paid more, but now it takes up more of my time. Why? The perception is that the radiologist needs to be in the room. I'm never in the room unless they have a problem or it's a very difficult case and the sonographer doesn't feel comfortable sending it through without me looking at it and deciding if we need to do another injection. This happens rarely. And again, better training of the sonographers is the key. And again, ICUS is working on this. We have a whole section of board members that are sonographers that are really working on getting education to sonographers. And again, developing worksheets that list all the features of the exam in a way that the diagnosis is easily made. And again, one thing that we do is we try, if we believe that we need to do a contrast study at the time we find something, we try to get the physician to actually, in their order, say, if needed, go ahead and do it. We've not made as much headway as I would like on that. But, you know, in breast, 90+% of our physicians write in order diagnostic mammogram, ultrasound if indicated, biopsy if indicated, which saves enormous amounts of time because those patients get everything done right by each other. And then at the end of the exam, the doctor is notified that all this stuff was done. It saves the patient weeks of going back and forth and getting examinations. And again, you can do this in your ordering system. And again, we're trying to get this done, and we're moving a little bit towards this. But again, I think you should try to get this in your institution. So to summarize, ICUS has developed a large number of programs and educational material for both sonographers and physicians. However, we did not reach many of the radiologists that are needed to implement a CEUS program for a multitude of reasons. Education to overcome misconceptions and increase confidence in performing and interpreting these examinations is needed. And again, we're trying to work with the Society of Abdominal Radiology, the Society of Radiologists in Ultrasound, RSNA, and some of the other organizations to include these and point out the need that you are really causing disservice to your patients if you're not offering this within your institution. We need to reach the people that do not come to the ICUS meetings or attend ICUS webinars, and it's been a struggle to get CEUS programs into other radiology society meetings. Although we've had a little bit of progress, we really need more. And again, one thing that I have promoted is maybe we need to go to patients and let them know, and we do have patients that actually come from around the country because they've looked online. We had one patient from Florida. She had a renal mass. They did a nephrectomy. It was a benign lesion. She ran into renal failure. Now she developed a mass in the other kidney, and she didn't know what to do and was thinking that they're going to take out her other kidney and put her on dialysis. So she found us on the internet and flew up. And again, this was a benign mass. It had no enhancement. And I'm sure that the one that they took out her kidney for was the same. That's what it was on pathology. So that really was a disservice to that patient to not do a contrast ultrasound in that patient. I mean, she has really suffered severely because of that. So again, I think educating people and directly so that they demand this exam may be one way of doing that. So with that, I'm going to end and I'm going to stop sharing and we'll go back to the main screen. And Stephanie and I are here to answer questions that you may have on the topics we talked about, or I'm sure Stephanie and I would talk about anything you wanted to talk about ultrasound contrast.
Yes, if you can put your questions into the chat box, that's the way that we are able to answer them. So Richard, right at the moment, I don't see a question in our chat box, but why don't I ask you a question? So do you think that when we're dealing with things like AASLD and NCCN, that obviously, I know you always encourage me to try to do studies that highlight these areas of deficiency so that we can publish the data. But do you think that we will achieve enough pressure by future publications that we will be included ultimately?
Well, I would hope so. And you know, one thing that always comes back to me when I was a resident, the neuroradiologist, and at that time MR was just coming on track. And, you know, the neuroradiologist said to me, he said, you know, we all think that MR is so much greater than CT for head imaging. He said, but you know what? If we had MR imaging and we didn't have CT imaging and CT was a new modality, we'd all be jumping up and screaming, this is the greatest thing ever, because we're now seeing bone and we could never see it before. So again, you know, I think it's to point out to these people that maybe if we didn't have CT and MR contrast and we had ultrasound contrast first, that MR and CT would be fighting like we are to get their addition into the guidelines, because we do better sensitivity and specificity, we have less reactions. Would the FDA have given them a harder time to approve those agents now that we have this? And again, I think it's education. And it's not only radiologists, because NCCN is mostly oncologists. ASSLD is mostly hepatologists. We need to get the information out to them. We've had some luck with urologists actually publishing CEUS and kidney in their publications and highlighting it to urologists. So I think urologists are buying in. And clearly the pediatric group has really moved very, very strongly into using CEUS, and the U.S. News now will not rate the pediatric hospitals high unless they're doing CEUS.
Yeah, no, that's an absolutely excellent example. And of course, what is told by that example is that, you know, pediatric people, they recognize so acutely the demand for them to have another way of imaging, because of course it fell very heavily to CT scan, and that was never good for children.
Right.
But somehow, I don't know, it's a very anyways, I do hope so, and you know that in my own department, I try to design every study that I do with an impact on some guidelines somewhere.
So we do have a couple questions now in the chat box. One is from Davita. Amazing presentations. Thank you for this. Do you use CEUS for RFA in the role of ultrasound in intraoperative liver resections? So we used CEUS for RFA in case we published something is over 10 years ago that we find it extremely helpful. We've taught the anesthesia nurses how to administer the agents. So we would do a contrast injections during the RFA, and we can see if there's residual tumor. You know, there's a couple little tricks if you look in the literature on this, it works well for cryo also, but you're not going to do multiple injections on CT and MR at that setting. Here you can do as many injections as you want, and we found that this allows us to really make sure that you can do this. And Stephanie, I know that your interventional people use this immensely in Calgary. Yeah. Maybe you can talk about intraoperative liver resections.
I'll talk for a moment first about RFA. There is absolutely no doubt that we do now use CEUS at every stage of hepatocellular carcinoma management and any other tumor that would have RFA. So we use it for diagnosis, we use it for planning, So before we go to multidisciplinary discussion, we always have information about possible organs that might be injured by using RFA, and we make a choice of the procedure. And then, yes, my sonographers actually go to the room to assist. They're pre-booked, and they go to assist every ablative therapy. And then in addition to that, we're now an integrated part of secondary surveillance. So we alternate with MR at 3 monthly intervals following these procedures being done. So that's a really, really great reason to use contrast ultrasound. Now, the role of ultrasound in intraoperative liver resections, yeah, the answer is yes, you can definitely use it there. But so great question, Kavita, and yes, I think that those are just great indications. And had I had more time, I would have included them.
Yeah.
So Paul Freiberger has another question. What do you think the institutional roadblocks are to your and many other institutions adopting the CEUS of indicated approach, not counting ultrasound CEUS training? It seems like common sense. So actually, so for me to answer that question, I'm obviously answering it as a Canadian, and Richard feels that I do what I'm going to do regardless, so that he always comments on that. But certainly, it's absolutely essential that your clinical body that sends cases to you recognizes that they're sending them to you because you have a strength in doing contrast enhanced ultrasound. And so that's absolutely right. Like, nobody in my entire institution would expect me to phone them to say, can we give an injection? So they put both my name and they put CEUS on the requisition, so that it's very clear that yes, if we wish to do CEUS, we will go ahead and do so. I think it's a great thing that Richard brought that up.
Yeah, so we have no problem with doing this in our, again, I'm in a private practice outpatient setting. Our breast situation uses this every day. And we have got almost all of the physicians, greater than 90% of the referring physicians, always send diagnostic mammogram, ultrasound if indicated, biopsy if indicated. So the patient just flows through our department. We don't have to call the doctor. We have nurses to talk to the patient. We just move forward and do this. Now, we still have a couple hangout physicians who insist that we have to tell them before they do it. And then it's lunchtime and we can't find them. The patient sits around for an hour. Then we find them and it's another hour before the script comes. So it really creates a problem. And I think the situation for us in terms of liver, where this is most useful, is in a young woman that has a lesion that could be an FNH. So we find these lesions, we can't make the diagnosis on a without scan. If we call it a lesion on an ultrasound B mode without, they go to CT. And then on CT, it's usually indeterminate, they can't make the diagnosis. Then they go to MR, and again, the timing is off, they can't make the diagnosis. So if we would have just done a CEUS study at the time the patient was there, we would have made the diagnosis of FNH, she would have been done, she wouldn't have had to go through all those other examinations. It could take months at some institutions to go through. And God forbid that she ended up getting a biopsy. So I think it's really, really helpful. And again, it's education not only of the radiologist, but of our referring physicians to know, give us the ability to make a diagnosis and expedite patient care by doing what we need to do.
So when we wrote the little publication that Richard and I both participated in about increasing utilization of CEUS, one of the things that we really emphasized in there was that as you're growing your practice, the most important thing is to make sure that your clinicians are aware whenever you do things that particularly benefit their patients. And so certainly clinicians very quickly, they remember when you did this before. So young patients with incidental liver masses, I think clinicians very quickly learn, gee, I can send it for a contrast ultrasound. It'll probably be done within a week as compared to waiting much longer for a CT or MR. And so I agree that that kind of exposure and familiarity with the tests is what leads to that. But it is great if you can have that added, that you always do CEUS.
So Kavita has another question about breast cryoablation. Actually, we do have a patient that had cryoablation of the breast, and she comes to us for CEUS for follow-up. Obviously, we get fat necrosis, and we get all these other changes, and it's very, very difficult to decide if there's residual tumor or not. And other than doing serial MRs with contrast, we do serial CEUS with contrast, and it works very well. And Tamara has a question: is CEUS being used for targeted chemotherapy administration? So yes, it is. It's a research tool. It's not FDA approved and widely used, but it's used in there's several different, this is very interesting. And if you're interested in this, I really recommend you come to the ICUS annual meeting, because this is usually discussed in great detail with the researchers doing this. So not only can we put chemotherapy in the bubbles and then bust the bubbles where we want the chemotherapy to go, but using the bubbles just by themselves and busting them in the area opens up the endothelial cells and allows the chemotherapy to go in. So the chemotherapy is not actually in the bubbles. It's just given at the same time we're bursting the bubble, and it allows the cells to open up and receive the chemotherapy. So there's a lot of very, very interesting things going on. And there's some other interesting things that there's a group in the UK that's looking at using the bubbles and evaluation of heart attacks. So they actually are doing a study where all of their ambulances and people in the ambulances are trained to give them micro bubbles and to use just ultrasound with high power to bust the bubbles over the heart. And they have found that this helps to lyse the clot. So they can actually give this while they're in the ambulance. And the reports are coming in that this is very helpful. So I think there's a lot of therapy treatments that are coming down the line. They're probably still 5 years away before they're going to be FDA approved to be used, but really a lot of information there. And these are really highlighted often in the ICUS annual meeting in Chicago, which is going to be in end of September or the beginning of October. I can't remember this year. So if you're really interested in that, you could come and meet all the people doing all this work.
I think it's September 7th is one of the days when it's going to be this year. It is absolutely an exposure to all aspects of using microbubbles, from the physicists and from the clinicians and the cardiologists. It's quite an exciting, interesting meeting.
Yeah, and it's a small group, and there's a lot of activities that you can talk to the people that are actually doing these studies. It's a very, very nice, informal educational meeting. And I see that our guys that are controlling this are telling us it's time to leave. So again, thank you all for listening to this. We hope it's very helpful. And again, please all join the ICUS organization. It's free. Get onto that website and see all that beautiful information we have.
And if somebody asks you if you can do contrast enhanced ultrasound, please say yes, you'd be very interested in doing this. So, and no one regrets starting to do CEUS. So thanks, Richard. Thank you, Northwest, for your assistance. And hopefully we will see you at another webinar in the near future. Goodbye.